receives blood from the body, one receives blood from the lungs. One pumps to the lungs, one pumps to the body. One receives oxygenated blood, one receives deoxygenated blood. And go back over the 21 steps of circulation. Nervous system control of the heart. So, sympathetic and parasympathetic nervous system. If I stimulate the sympathetic nervous system, what would happen? If I stimulate the parasympathetic, what would happen? If I block the sympathetic, what would happen? If I block the parasympathetic, what would happen? All right. Anginal or coronary syndrome equivalence, right? Chest pain is the obvious, or chest pressure. And be careful, because sometimes you'll ask, are you having chest pain? And people go, no, I wouldn't call it pain, it's more of a pressure or squeeze. Yeah. But other things that could be indicative of a cardiac problem.
And you said that was anginal versus what?
Or coronary syndrome equivalence.
Okay.
This could be, weakness, dizziness, lightheaded, nausea, right? Shortness of breath, jaw pain, arm pain, fatigue, palpitations. It doesn't have to be chest pain. There's a list, and you have to decide which one is or is not. Left side versus right side heart failure. Right. Left side failure, blood backs up to the lungs. Right side failure, blood backs up to the body. So keep in mind the signs and symptoms you would see for left side versus right side heart failure. The different heart sounds. Sound 1, sound 2, sound 3, sound 4. Love, dub, da, and blah, and what they mean. Like, what is love, what is dub?
Like S1, S2 type stuff?
Yes. The electrical conduction system of the heart starts normally with the SA node. Right? Travels through the internodal pathways to the AV node, then through the bundle of His, and down the bundle branches, ending with the Purkinje fibers. Know the basic inherent or normal heart rates of each of the pacemaker sites. And always remember, whoever's fastest is going to be the one pacing the heart, driving the heart. Refractory. Talked about that on the ECG. There's an absolute refractory period, meaning I cannot get the heart to contract again. And a relative refractory, meaning I can get it to contract again, although it would be weaker, not as strong of a contraction. So what is the refractory period? The heart is doing what? It's depolarized, or it's in the process of repolarizing. This is A&P, and I didn't really talk about this. We did this last semester, but should have reviewed anatomy of the heart. The SA node, where is it located?
Atria.
It's up in the right atria part of the heart. So it's going to receive blood from what coronary artery? Right or left?
Right.
Yeah, be buried in grad school. Don't overthink it. Just like on your drug quiz today, where I didn't ask the initial dose of adenosine, I asked the second dose. Read these questions carefully, because if I said the pacemaker, the normal pacemaker of the heart failed, who would take over? If I said the second pacemaker failed, who would take over? You get the idea? Make sure you're reading carefully. Ooh, some really tricky ones here. What does the P wave indicate? What does the QRS indicate? What does the T wave indicate? What does the PR interval indicate? What is a normal PR interval? What is a normal QRS width? normal heart rate. Those QRS and PR interval distances can be expressed in, can be expressed in time, or it can be expressed in boxes, right? So how much is one tiny little box in time? 0.04 seconds. Where should the ST segment be normally?
Which
Is it
segment?
above the line, below the line, or on the isoelectric line? There are multiple questions about CPR. They're all adult questions, so, what is the normal rate? What is the normal ratio? What is the normal depth? What is the qualities of good CPR, like full recoil? You know, how long can I pause for a pulse check? All those CPR type questions. Make sure you review the difference between compression to ventilation ratios when I have an advanced airway and when I don't have an advanced airway. What do we mean by advanced airway?
ET tubes. Supraglottic.
More than an OPA or NPA. OPA, NPA are basic. Everything else is advanced. So a King tube, an iGel, a Combi tube, those are all considered advanced. It doesn't have to be an ET tube. So I know we're used to like, oh, an EMT puts in a King tube, that is still considered an advanced airway.
Bless you.
There are questions about cardiac arrest or cardiac rhythm treatments. So, for example, you're doing VFib and you shock the patient. The very next thing you should do is not a pulse check? No, CPR, correct. The dose for epi or atropine or whatever, the dose for amiodarone, pay attention in cardiac arrest or if there was a VTAC with a pulse. Doses are different, remember that. There are questions that will use the term refractory, right? For example, this is refractory VFib, meaning what you did didn't work. What is the next step? So which drug would you give in refractory VFib, or VFib that is refractory to epi? The next drug would be?
Amnio.
Or Lido, or, you know. Refractory means the treatment I did didn't work. So what's your next choice?
Like the rhythm persists?
They're in sinus Brady at 30. It is refractory to atropine. Atropine did not work. What's the next thing you want to do? Okay. Refractory means it just, what you did didn't work. Please know which rhythms we can defibrillate and which ones we cannot. Doing CPR, working a code, resuscitating someone in cardiac arrest. When is it appropriate to stop or pause, not stop, not terminate, pause compressions? Should I pause compressions so somebody can intubate? No. When I defibrillate, yes. Can I pause? Should I pause while somebody gives a drug? No. Should I pause when somebody gets an IO?
No.
right? So 2 times I should pause CPR,
Pulse check.
Every shot.
Defib.
pulse checks and
Defib.
cardiac rhythm defibrillation, or rhythm assessment. Like I have to stop so I can see what the squiggly line is. Otherwise I just see CPR. You know. Shock and rhythm analysis, yes. Which is a common causes of cardiac arrest. Oh, that's pretty easy. Just read carefully. I can already see where people read too quickly on that. There are questions regarding this stuff, but I will warn you, there will be, it's not a trick question. For example, if the person had SVT, stable, would we give 30 milligrams of adenosine? Would I give 0.25 milligrams per kilogram of Cardizem? You know, so they may have the right drug, but the wrong dose. You gotta make sure you're picking the right. Okay. Like, okay, during cardiac arrest, we're doing CPR. We're not gonna give 2 to 10 micrograms a minute of epi. Right? We would give 1 milligram of epi. If it said 1 milligram of 1 to 1,000, would that be correct? No. Read carefully, is my point here.
Gender fluid.
Please know what pacing is, the difference between electrical and mechanical capture, the procedure. Treatment of bradycardia, well, let me back up. Treatment of 3rd degree heart block.
Hospital.
What's the first thing I want to do? Why not action?
Because you're already that far on.
Not gonna work. Remember to treat your patients, not your monitors.
It's the 1st and 2nd degree heart block that you.
Atropine works.
Okay.
It's 2nd, type 2, and 3rd degree. It doesn't really work.
Okay,
It definitely doesn't work in 3rd degree.
so no drug.
No atropine.
Atropine,
I
okay.
can't take the vagus nerve away. I can give atropine, I can give dopamine, but just atropine doesn't work in 3rd degree. How do we calculate cardiac output? Times stroke volume and heart rate, right? So why do we get compromised cardiac output or poor cardiac output with heart rates less than 50 or greater than 150?
Because the heart
Doesn't have time to refill.
Not the stroke volume, it's the rate usually. Please know what re-entry is. That's when a signal goes through and it loops back and keeps going through the same part of the heart, re-enters the electrical pathway. So it causes what to happen? Tachycardia. The same signal is stimulating over and over and over and over. No, that's not re-entry. It can cause re-entry, but that's a bypass track. All right, lead 1, lead 2, lead 3, Einthoven's triangle, right? Know which way they go, like lead 1 goes right arm to left arm, lead 2 goes right arm to left leg, lead 3 goes left arm to left leg. Know which one is positive, which one is negative. In whatever lead, all right, let's say lead 1. If the signal moves closer to the camera, which way does it go on the ECG paper? All right, and vice versa.
What is it called again? The triangle?
Einthoven, E-I-N-T-H-O-V-E-N. There are multiple questions on positive, negative, which is which lead, type thing. The QT interval, right, Q wave and T wave, is a representation of the heart, the ventricles being depolarized or repolarizing. Prolonged QT is a contraindication for some meds, like Zofran, right? how long is a long QT? Or how long is a normal QT?
0.12.
Wait, sorry.
0.12.
PR,
Yeah.
the QT.
0.40.
0.12 seconds.
450 milliseconds. It's actually just over 11 little boxes.
Oh, really?
The entire QRS, ST segment, and T wave.
Oh, okay.
So 440 would be 11 boxes, right?
That's the what interval?
QT,
Sorry, it's random question.
is that what I'm looking at?
You should make
Oh,
it
that's
something.
corrected for
It
you.
sounds like cutie.
Males and females, it's slightly different. The different methods for calculating heart rate. 300, 150, 100, 700, or the 6-second strip, or, you know, should be familiar with the different methods. Remember the steps for ECG interpretation? I'm not asking you them in order, but there may be questions that say, which of the following would you routinely check? So like, looking at an ECG rhythm, do we look at T waves?
No.
Do we look at ST segments? Do we look at P waves? QRSs? Get the idea? There are several multiple questions about the characteristics of a junctional rhythm are, the characteristics of atrial fib are, you know, like what are the QRS with, the P wave, you know. There are also multiple questions that will say things like, you see a regular rhythm with a heart rate of 70, with a QRS that is 0.08, and inverted P waves. What is this rhythm? No. Accelerated junction,
Oh, because it's.
over 60. Right? But my point is, it either gives you all the characteristics, what is it? Or it's what are the characteristics of this rhythm, and you would have to know which, you know, like it says like a sinus rhythm, right? So inverted P waves. No. QRS that is 140 milliseconds. No, that's too wide. A rate of 80. A PR interval of 0.24. No, that's too long. No. So like which one is a characteristic? You get the idea?
I'm like, wait a
Right.
minute.
Causes of bradycardia, causes of tachycardia. Like, person has a slow heartbeat. Is that because they did too much meth?
No,
4 lines of coke?
no,
Drank a bunch of caffeine?
no,
Smoked a bunch of cigarettes?
no.
You know, which is a cause of, you know, you get the idea. ECG paper. How big's a little box? 1 milliliter, one millimeter by 1 millimeter. How much time is in a little box? 0.04 seconds, okay. 6 seconds would be how many big boxes?
30.
Just shout it out. What does a prolonged PR interval mean? What does the term aberrancy mean? Abnormal conduction. What is the J points? I think some of these were like worksheet questions, yeah. And I apologize, it was listed as homework, it's actually worksheet. Tomato, tomato. There are definitely questions about PDCs, PACs, PJCs. There are questions that will compare two different heart rhythms. For example, the difference between a junctional rhythm and a sinus bradycardia is where it comes from, but specifically a
P wave.
inverted P wave or an absent P wave, you know. What is SVT? There are some very fairly easy one, like, what is the classic sign of atrial fibrillation?
Oh, the
Irregularly, what's the classic sign of atrial flutter?
sawtooth.
Picket fence, sawtooth pattern, you know, you get the idea. What's the big problem or complication for people with AFib?
Blood clots.
Blood clots. Blood clots, which usually leads to strokes or pulmonary emboli. So there are questions on some, I don't want to say over the counter, they're probably prescription, but medications not the ones that we use for treatment. Right? And some of them. For example, if this person took nitro and aspirin, what kind of problems do they probably have?
Cardiac.
ACS, angina, something like that. If they took metoprolol, probably blood pressure, but it could also be heart rate, tachycardia. If they took digoxin or lanoxin,
Low heart rate. High heart rate. No heart rate.
all right, enough guessing. Digoxin or lanoxin, it's the same drug, different name, is like the #1 drug prescribed for AFib. And when I say the #1, it's like 99.9% of what is prescribed for AFib. So Dig or lanoxin would be definitely AFib. If they took insulin, what history do they have?
Diabetes.
You get the idea. So by giving you some meds, you can kind of come up with what the history is. If they also are in AFib, because we're worried about clots, what else would they probably take?
Blood thinner.
A blood thinner like
Warfarin.
Coumadin, warfarin, could be aspirin, could be Plavix,
Is that what this one?
Eliquis. Lots of questions about ECG rhythm characteristics. For example, you see an upright P wave, you see a QRS that is 0.08, you see a rate of 90, it is regular, and the PR interval is 0.24. That would be what?
Mosaic.
Normal size.
PR is 0.24. Sinus with a first degree heart block. You know, where it gives you the characteristic, there's a bunch of those type of questions. You see a electrical beat that does not look like any of the other electrical beats that came a little bit early and is a wide QRS. You see several of them that have different shapes. Multifocal, you know, you get the idea. They will use the term Mobitz type 1 and Mobitz type 2 for your second degree heart blocks. Second degree type 1 is Mobitz 1, second degree type 2 is Mobitz 2. Also known as, second degree type 1 is also a Winky-Bach. If an electrical signal started in the ventricles, what would it look like? Wide QRS. The term idioventricular. Right, is wide, and idio is basically, because we can't call it brady, is basically slow ventricular. So how would they present? Signs and symptoms. Would they be stable or not?
No.
What's the normal ventricular rate?
20 to 40.
20 to 40. And this is a slow ventricular rate. They're probably gonna look,
Dead.
I was gonna say really bad. Just like PVCs can be multifocal or unifocal, VTAC can be monomorphic or polymorphic, which is also known as torsades, polymorphic. If I don't treat VTAC, what does it become? If I don't treat VFib, what does it become? What is the R on T phenomenon?
The T wave and the R wave sort of merge, start to merge.
And then it hits it, and then they fucking die.
We go VTAC. Remember, you can do CPR while your defibrillator charges. How long can we do a pulse check? Right after we shock somebody, defibrillate somebody, we should.
CPR.
CPR. What are your H's and T's? You don't have to name them, just review them. There are multiple scenario type questions pertaining to those like H's and T's. Right. So you've been doing CPR, blah, 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 for the last 15 minutes, and the husband says, yeah, my wife's had diarrhea for the last 4 days.
Oh, hypovolemic.
Right? Or you notice it's gotten hard to bag, you don't hear lung sounds on the right, you see brachial deviation to the left. That's your pneumo. You get the idea. What are the chemical ions for depolarization? What goes rushing in the cell?
Calcium. Potassium. Sorry.
Sodium.
Oh.
Sodium goes in,
Potassium.
potassium comes out, and then calcium goes in. So with repolarizing, the opposite. The channels close and the pumps have to pump everything back to where it began. There's that refractory term again. Like if they were refractory to defibrillation, what did that mean? So my next thing would be a
CPR.
well, CPR and
Well,
a
medication.
drug of some kind. The only other friendly piece of advice I will give you on this is put your personal opinions aside on some of these, because I know there are several of these you're like, yeah, no code, no vitals. No, no. We should be working them, we should be compassionate, so. Don't just be like, oh yeah, the drug dealer was found, no, he's dead. No, like, have a little bit of that, just a little bit. Yeah, a really good review. Those ECG characteristics and ECG, that's probably a third of the test. And that is a big chunk of the test. The numbers there. This will not have a printed ECG, which you tell me what, it gives you the characteristics. The printed ones you'll get on the ECG list. Okay? So, any other questions?
I was doing this
How would I? Probably at the level of your airway